can always refer to a specialist once you get the diagnosis, but getting the diagnosis is the hard part. So I think what we have to do as a country is say, how can we make this as easy as possible, right? And I think there's some things that are actually current right now that is going to do that. And those are gene panels, right? So Invitae, Natera, et cetera, they have gene panels. So now if I think CKD as a nephrologist, I don't have to think, what could this be? I just say, this could be genetic. I'm going to send a panel of 400 genes. One of those is Fabry disease, right? And now I don't, then when it comes back positive, I say, all right, well, I'll learn about that disease because my patient has it, right? So sending gene panels, I think, is going to absolutely change how we diagnose anything in renal genetics. Because it used to be when I had a patient with renal genetics, I tell the patient, well, I think it's this. So that test might cost $3,000 for one gene. And when that test came back negative, I had to say to the patient, well, it's not that, but there's 5 other genes that it could also be, right? I just picked the one gene that was wrong out of 19,000 other genes, et cetera, that could it be. But once you start collating all of this genetic information into a renal panel, now I can make the diagnosis. And that's what cardiology did. So cardiology has a hypertrophic cardiomyopathy gene panel, so that when they have hypertrophic cardiomyopathy, they don't have to think of all the different things that cause it. They just send the panel. And lo and behold, we're getting diagnoses from cardiology. Nephrology now has that advantage, and I think that they've come a long way, not only with affordability, but with interpretations of these gene panels, so that now any nephrologist can say, I think this is genetic. Don't just say I'm done, send the panel, right? And you have to know the limitations of the panel, but those panels are going to change it. So we need to stop thinking that every single physician is going to know every single rare disease, because it's just not a tenable area, especially as we learn more and more. But it should be an expectation in the future that every nephrologist sends a gene panel on these disease states, because it has usability not only for that disease, but also in transplant, right? How we manage transplant failure, et cetera. So the gene panels is really where I think we're going to start making headway on these disease states. And I can see one for stroke, right? So now there's a gene panel for CADASIL. So these are patients who have stroke before the age of 50, which likely have some sort of genetic component. So you start taking these syndromes and you break out all of the genes that can cause that, and now we can diagnose it. When you diagnose it, then I think that people need to enlist the help of someone who really specializes in that to help guide therapy. And as the medical director of telehealth for UAB, one of the reasons I got into telehealth was this idea that we could actually get regional centers of expertise and then co-manage rare disease with primary care physicians to make sure every patient had access to super subspecialties that manage that disease state. I mean, because geography should not dictate whether or not a patient has access to the best care. When you start screening for disease, the patient already has disease, right? So for instance, when I have someone whose creatinine is elevated, they already have chronic kidney disease, right? So now I know that the number of people I need to test goes from 40,000 down to, say, 5,000. So cost goes way down when I am targeting patient populations that are enriched for any disease state, right? Which is why these gene panels really are powerful. You have to worry about insurability, but once again, the patient's chronic kidney disease has likely already affected insurability. So the addition that this is Fabry disease is a little bit cleaner, right? There's a direct benefit to that person. And now you can spread out and identify the family. If you've identified the family, if you identify enough families, guess what? You've done newborn screening even before the newborn is born, because you've identified the mom and dad who have the gene. So I think we got to take this in pieces. And I don't think there is many who would dissent that said, I have a patient in front of me with chronic kidney disease, I need to test, so I'm going to test, as opposed to I have to test 40,000 people with this gene state. I think with Fabry disease, or to find one patient with this gene state, I think where it's really hit an ethical dilemma, I believe it was Krabbe disease. So there's some of these lysosomal storage diseases that lots and lots of money went into, and the outcomes of those newborn screenings uh, didn't necessarily change the outcome of the disease state, right? So we got to be careful in not just escalating cost, but making sure that the cost is justified. And I think that justifiability is absolutely there when we start talking about identifying a proband with a disease state.